Good morning from Miami. This is Dr. John Bennett broadcasting live from the Neurosurgical TV channel. This is part of the ACNS conference on skull-based surgery and a few other topics. Today we have the pleasure of having Ramesh Nair MD. He's a neurosurgeon originally from India, but now he's practicing in London, England. And first, let me introduce the panel before I turn it over to Ramesh. Good day, Ipe. How are you doing?
Hi, Ramesh. I'm looking forward to your talk. Thank you.
Thank you, Ipe. And Rakesh.
Hi everyone, I'm Dr. Rakesh AV, a neurosurgery resident from India. Great to have in the panel list with the great neurosurgeons here, and I'm looking forward for Dr. Ramesh Nair's presentation. Thank you.
Welcome, Rakesh, and my main man, Simon.
Hello, thank you for allowing me to be here. My name is Simon. I'm a medical student in Tokyo. Thank you very much.
Okay, Ramesh, thank you for coming out today, and it's all yours.
Thank you, John, and thank you, Ipe and Rakesh and Simon. It's good to see you all this morning. It's a fine morning in London today. The weather is very good. We have something planned in the afternoon, like a walk in the park. So I'm looking forward to this after this talk. What I want to do is to show at least two cases, possibly three cases. And it's good to have my close friends like Ipe in the meeting, so I could get their opinion as well. So I'll start off with my first case. So the first case is a 48 years old Afghan male who was admitted in my department under another colleague of mine with an acute, with a collapse. And he was brought to the hospital. He had to be tubed and ventilated, and he went on to have a CT scan. As you can see from the CT scan, the CT shows that he has got an area of hemorrhage, especially around the lower pons and the brainstem. And you can see there is some hemorrhage within the fourth ventricle. The brain posterior fossa looks a bit tight, and also you can see the subarachnoid hemorrhage around the brainstem. Even the scan slices higher up, you can see the ventricular hemorrhage in the third ventricle. The brain overall looked tight, and he subsequently went on to have an external ventricular drain put in. And he went on to have further investigations, including CT angiogram and a cerebral angiogram. So this is another shot showing the extent of hemorrhage he has. You can see the diffuse subarachnoid hemorrhage, mainly in the posterior fossa, and the fourth ventricle is completely full of blood. And then the next, the CT angiogram which he had, I have not shown the pictures of the CT angiogram, is suggested a possibility of dural AV fistula, mainly in the skull base. Draining into the posterior fossa, possibly into the vertebral canal, and the diagnosis was that he's got a posterior AV fistula. And as we do with the posterior fistulas, the first refusal in terms of management was given to my interventional colleagues and asked them to see whether they have any options to treat this guy. So they went on and did an angiogram. So I'll just explain this particular slide here. But this is the right carotid angiogram. And what you see here is the carotid. You see the carotid here and the siphon here. But the most marked finding in this picture is that you see this branch which comes off the cavernous segment of the carotid artery. It's a tortuous artery that goes around along the petrous ridge, and then you see a venous varix, and that drains into the posterior fossa here. So this is the meningiohypophyseal trunk. One of the tendural branch is hypertrophied, and that supplies the superior petrosal sinus wall, and then it drains into the sinus, and then from there it drains into the posterior fossa through a big vein, which I suspect was the petrosal vein of Dandy. You can see also another branch, a tortuous branch, which is a meningeal branch. That meningeal branch is coming off the middle meningeal artery. Let's see another shot. So this is the the anterior posterior view of the, sorry, I did say right, it was a left internal carotid artery projection. So you can see the meningiohypophyseal trunk with a tortuous feeder going along the superior petrous apex. So it's a feeder that travels along the petrous ridge, along the superior petrous sinus. And you can see the venous varix, and then the vein that is draining into the posterior fossa. So this is a dural fistula based on the petrous ridge along the superior petrous sinus. There was also another feeder coming from the occipital artery, which we will see it in one of the MR scans. But these are the main two feeders, one from the middle meningeal artery, and the other one is from the meningiohypophyseal trunk from the cavernous segment of the carotid artery, and it drains into the posterior circulation. And this, you see this a large a sac of blood here, and that is the hemorrhage from this venous varix here. So this is responsible for the venous hemorrhage he had in his brainstem. And this is the external carotid angio. You can see the middle meningeal artery. You can see the feeder that travels along the floor of the middle cranial fossa, coming up to the petrous ridge and supplies the superior petrosinus wall along the petrous ridge. So this is the MR scan. I'll just explain the MR again. This is the T2 weighted MRI scan showing a large venous sac with some hemorrhage within the brainstem, and you can also see a prominent vessel, which is one of the draining veins. You can see the large venous sac and the hemorrhage within the posterior fossa, a lot of swelling around the brainstem, and you can see this venous structure here just behind the trigeminal nerve. So the location will fit in with the petrosal vein of Verdandi here. And going on to the MR time of flight images, showing the petrous ridge, you can see the whole of the petrous ridge is sort of enhancing with the arterial structures. There is a feeder coming off here, and you can see the hypertrophied meningiohypophyseal trunk, and the rest of it you see it in other slices. And this ridge is all well delineated with the MR scans. Again, that again shows the feeder that is coming from the cavernous segment. The other feeder I was talking about was the occipital artery. You can see the occipital artery then gives off in a transosseous feeder, which then will travel along the inner table and then goes out. This is the sigmoid sinus, and then goes outside the sigmoid sinus and then travels to the petrous apex here. So you can see that branch is just coming from here and then going around the sigmoid sinus, and will eventually reach the petrous ridge. The other finding in this MRI scan is this meningeal feeder you see here. So that small dot is the middle meningeal artery feeder coming from the middle cranial fossa. So the radiologist was concerned about the interventional option. They tried to cannulate the meningiohypophyseal trunk. They failed it. They tried to cannulate the middle meningeal feeder. They failed to do it. So finally, they had to abandon the interventional option. So the only option this guy had was a possible surgical option, and he, because of his brainstem swelling and lower cranial palsies, he needed to have ventilator support. He was not doing medically great with chest infection, and also had an IVC filter put in for PE, so he was not doing great. And the surgical option was delayed for some time till he became at least optimal medically. And he had external ventricular drain to tide over his hydrocephalus, which we had to keep for at least a few weeks. Eventually, that got infected. He had to be treated for meningitis. And once he became optimized from a medical point of view, I decided I took over the case and decided to consider a surgical approach. So at this stage, my dilemma was what sort of surgical approach I have to do, whether it's going to be a retrosigmoid approach to see the putrescent vein and the venous connection of the fistula, because that's in fistulas the primary aim is to disconnect the venous structures. That's what the interventionist also would like to do for fistulas. It's not like an AVM, because you want to disconnect the fistula, which transmits the venous pressure. John, are you able to hear me?
Yes, yes, yes.
Okay. So
hello.
Hi.
I'm able to hear you. I'm able to hear you.
Yeah. So I was thinking about two approaches. One is a subtemporal approach and see the petrous ridge and then bus all the feeders, and then trying to open up the tentorium and then see the posterior fossa and then ligate the vein. The second option I had was a retrosigmoid approach to see the vein, and that is, that's the primary aim of this operation, is to disconnect the venous structure so that there's no venous pressure reflected back onto the brainstem. That, in fact, I forgot to mention, while waiting for all this medical optimization, he re-bled at least 3 times. So in fact, he went on to have an shunt EVD converted to a shunt, and then he bled, and then the shunt had to be taken out and the EVD had to be put back in. So this is a guy who was a high risk for re-bleed, and so the intention was to disconnect the venous channel. I was, for a while, till the day of the operation, I was debating between the two approaches. Do you have any comment to make at this point? What sort of approaches you would consider?
Ramesh, see, this is a clear-cut dural AV fistula. The main supply is the artery of Bernasconi and Casanare, and it is coming through the tent. And the middle meningeal artery is also coming through the tent. I mean, its middle meningeal artery is also there. So in this case, what I would want to do is reach the fistula as well as cut off its supply. So what I would go for is a FOZ, because I'm very confident of this approach. So I will do an FOZ, and then I'll combine it with a I will combine it with a petrosal approach, so that I don't have to drill the petrous base or anything, but I'll go to the base, I will buzz off, and I'll cut the tent. Once I cut the tent, I will retract the temporal lobe of the tent, and I will cut the tent. Once, if I dissect the cavernous sinus at the C5 top, I'll be able to see the meningohypophyseal artery coming out. That is if I have a lot of difficulty. But if I buzz and cut the tent, I'm effectively going to take out the supply here. And middle meningeal artery, doing the same approach, I'll be able to take out the middle meningeal as well, because I can just buzz the middle meningeal artery and take it off. And then I'm left with only one supply, that is the occipital artery. I would not be too much worried about it. I'll open the membrane of Lilliquist, go into the prepontine cistern, go lateral to it, and see if you saw the bleeding is actually posteriorly. So unless I'm able to get there from a lateral perspective, or almost on a subtemporal perspective, I really wouldn't go in and do anything. And if I am able to, I'll take it off, or otherwise I'll come from a retrosec. Okay,
I take the point, and I did think about the anterior approach for this case. As you mentioned, it's the feeders. If you can tackle, it's a good thing to tackle the feeders first, and then you will be essentially devasculating the fistula. But also in fistulas, one of the primary aim is to disconnect the vein. So I was concerned whether when I go subtemporally after opening the tent, will I be able to see the venous tributaries clearly? If I miss some venous connection, that probably can recur. That was my concern. And so I finally decided to do a posterior fossa approach, sort of a retrosigmoid approach. So that's the main intention, was to see that the draining vein from it. Even if I couldn't take the feeders, once you disconnect the venous channel, then you don't have a risk of further hemorrhages. And in many occasions, the intervention neuroradiology, they rather than, if they cannot take the feeders, what they would do is to try and occlude that portion of the sinus. So essentially, they would cut off that sinus by embolizing it in the venous side. So then you disconnect the cortical venous reflexes. So that is a sort of a principle they use. So that's the same concern I have with this case as well. So I decided to go for a retrosigmoid approach. I could not do it in a lateral position because as soon as I put him in a lateral position, this was last week I operated. As soon as I put him in lateral position, the anesthetist was really concerned about his chest. The pressure went up. So they said the one of the lung is not moving. So I had to put him back on his in the supine position. So I had to do it in supine position with the head turned tilted to one side. So this is the approach on the left side. What you see here is the dura stitch towards the petrous bone here, and just using the scissors to open up the that's the tendorium you see there. That's the posterior petrous surface you see here. I'm just trying to locate the venous the fistula. So opening the cisterns around it. And just if there's any residents or trainees listening, my preference is to avoid direct contact with instruments onto the brain. So I use a Surgicel to cover the cerebellum first, and then use cotton patties or lintine, what we call it, to gently push the cerebellum away. And then so there is no direct contact between the suction or any other instrument with the brain. So just going to fast forward it. So this is just to. So I'm just trying to orient myself with the anatomy here. So I'm just opening up the cisterns lower down to look for the cranial nerves. Just for the sake of training here. So the first nerves you see in this location. This is similar to an extended MVD. The first nerve you would encounter is the 7th and 8th cranial nerves. It's not the 5th nerve. 5th nerve is much more deeper, and 7th and 8th much more superficial. So when you do an MED or try to see the 5th nerve for any other reason, before you retract, you have to be careful that you don't retract the 7th and 8th nerve, because 8th nerve is quite vulnerable and sensitive, and even minor retraction of the 8th nerve can lead to deafness. So that is one thing. So the 7th and 8th nerve, let's see if I can see that. We can see the arachnoid here. That's the 7th and 8th nerve under that arachnoid. Just going to move it forward a little bit. So that's the 7th and 8th nerve. Can you see that there? And the arachnoid is just cut to release it so that I can retract it a bit more safely. So you can see with the proper positioning, you don't need to put any retractions on the cerebellum. So just dividing it. Let me just go on to the next one. So I'm just defining the venous fistula here. So you can see the big petrosal vein, and in the deep aspect of the exposure, you can see the 5th nerve running. And I'm just trying to get some anatomy here. You can see the big venous channel here. This was almost like an arterialized vein. Normally you see a deep bluish vein with the petrosal vein, but everything looked like an artery. But it is coming off the tent here. So just inserting the vein around to get the. So just moving around. So this is the fistula point. You can see the petrosal vein will be in this direction. The tent is here, and the petrous surface is here. And I'm just exposing the fistula point. There's a big venous varix here. Just move it forward a little bit. So again, that's a big venous channel going deeper. That is towards where the hematoma was. So as soon as I define it, let me just Again, the fifth nerve just anterior to this venous tributary. I'll be trying to define this vein here, and then so you can see that the venous varix, and it's coming off the superior pituitary sinus. Again, so when I did the craniectomy, the dura was quite tense. He did have an EVD which wasn't draining well for a day or two, so I had to put a occipital burr hole at the same time of this operation to release the CSF. There's another technique one can use when you have to open up the posterior fossa. It's rather to release some CSF when you have a tight brain, especially in the posterior fossa, don't open the dura unless you can drain some CSF from somewhere. For large acoustic, my preference is to go down to the foramen magnum, so and also make a very tiny incision at the lower part of the fossa in the foramen magnum area to access the cerebellum medullary system with a tiny dural incision, then drain the CSF from there. It's better not to open the dura where you want to open the dura for your acoustic neuromyxation, but to drain CSF to release the CSF. I never done any lumbar puncture or lumbar drainage for these sort of operations. You can always access CSF during these procedures. So in this particular case, because my craniectomy wasn't low enough to go to the foramen magnum, which I didn't need to, so I went to the occipital burr hole to release the CSF. So this is the this is a ligate clip I used to ligate so this is the vein being dissected. So you can see that big tributary is ligated with the ligate clip and bipolar coagulation. There was another tributary going straight down. They all look like arteries, but they are all arterialized veins. Again, that tributary is also divided. Normally for MVD procedures, I don't ligate the superior pituitary sinus. It's a standard procedure for many surgeons, but generally it's a good principle not to disrupt any veins unless you have to. So normally for a microvascular decompression, you can always leave the pituitary vein intact. But in this case, the pituitary vein was the culprit, so I had to take it. So you can see the tentorium here. There is a big venous varix here. So the tributaries are all disconnected. And let me just go. So this, I'm just disconnecting the second tributary. So it's completely disconnected, and then all I have to do is to take off the fistulous point. So disconnected, let's fast forward. So this is just making sure that the veins are all properly closed. This is a small ligate clip I'm using to occlude the vein. And for veins, you don't have to, just because it's an arterialized vein, I thought it's best to be extra careful when getting hemostasis. So this is all bipolaring that ridge, and then later on I will be opening the tent. So that's the fifth nerve, just to show the position of the fifth nerve. Yeah, this is that first tributary. This video is not in the proper order. So that's the first. So the vein is ligated. Okay, just forwarding it. That's coagulating the Okay, this is all shrinking and coagulating these veins before I ligate them. Just forward to the next slide. Okay. This is defining the vein. That's the other tributary going down. Just forward it again. So this is I'm just cauterizing the tendorium. Then I will open up the tent here along the parallel to the pituitary ridge, closer to the superior pituitary sinus, and then bipolar the pituitary sinus from this side. And I used a small upward sort of angled bipolar to go above the tent to bipolar the ridge from this direction. Let's see if I have that video. So this is opening the tent here, and so just opening the tent, and then eventually I'll be opening the entire length of the tent to go around this superior pituitary ridge, cauterizing the superior pituitary sinus. So it is, as you say, it's impossible to know whether you've cauterized all the feeders. But as much as I could, I tried to cauterize the superior pituitary sinus. But the primary aim of this operation is to disconnect this fistulous connection. So that was the first case, and I was hoping to get an angiogram yesterday, but then the interventionists couldn't do the angiogram yesterday. And hopefully they'll do it next Tuesday, and I have to make sure that there is no further connections. As long as I don't see any venous channels going into the posterior fossa, I think there's no major concern. Yeah, and during the exposure, I've taken the occipital feeder out, and hopefully the cutting the tendorium and cauterizing the superior pituitary sinus would have taken out the anterior feeders. But that's only of a secondary importance. The primary aim was to disconnect the venous channel. Any comment to make at this point, Aip or Rakesh or Simon? So I can proceed with the next one.
Yeah, Ramesh, can you hear me?
Yes.
For me, I'm not. I mean, I'm not a big fan of retrosigmoid, so probably that's why I probably opted for this first approach. But what you've done, what I have seen, I think what you did is a better choice than what I would have done.
Yeah, I think it's all about personal choice, and you are quite familiar with the orbitozygomatic, and I wasn't thinking about orbitozygomatic. I probably would have gone subtemporally to the pituitary apex and then cauterized the meningeal branch as well as the meningio-hypophyseal trunk running through the pituitary ridge, and then opened up the tendorium to see the posterior fossa. But my concern was that whether I could get a proper view of the pituitary vein and the tributaries to it. That was the main concern. So in the end, I chose the retrosigmoid approach. But I accept that you could have a wider exposure to the orbitozygomatic approach and see the tendril edge and all the main feeders from that approach as well.
No, but you wouldn't have been able to take the occipital artery. I mean, you did everything.
Yeah, that is true. But then you don't really have to. If you can disconnect the veins, and then even if there is an occipital artery supplied to the superior pituitary sinus, that's not going to give any further issues. There will be some of the cases. The fistula will persist, but as long as you disconnect those draining veins to the brain or posterior fossa, then it shouldn't cause any major issues.
No, we had a similar case last week actually. Let me see if I can share very similar case, but you can have. But it's completely.
Shall I just do the next case I have, and then at the end, if you could find that dural fistula, it would be good to have a look.
Yes. I already have it.
Yeah.
I mean, since you just presented this case, there was a bleed which came to us
Are you on? I mean, can I just switch off the screen share now and see that I can't see you now?
Can you see me now?
Okay, let me just see the.
Oh, you have to leave the screen share, Ramesh. You should click on the green arrow. There we go. There we go. Okay,
Yeah.
Mike is showing his screen now.
Okay, I can see your screen, Ike.
Can you see that?
Yeah.
So we had this patient with a echo aneurysm, and then we found a large vein sitting there. So
is that from the ophthalmic branch, which is
looks like from the ophthalmic?
Yeah, ethmoid branch is coming through the ethmoid foramen. Then
once I do the clinoidectomy and once I expose the ophthalmic, once I cut the distal dural ring, I should be able to. And once I expose the frontal base, I should be able to get this one. That's what I'm.
Have you done this case already, or are you planning to do it?
Yeah, I'm planning to do it. This would be for the next week.
Yeah. So I mean, my suggestion would be that it seems that the fistula is arising from the very anterior end of the anterior fossa. I have had a similar case in the past, but a slightly smaller one. There was a dural fistula at the front end of the anterior fossa. It seems the fistula is at the anterior aspect of the anterior fossa, so that's where the connection is. So I don't think you have to access the ophthalmic artery here. I would probably go around the anterior fossa and then see the feeders and then disconnect the vein here. That should be sufficient.
The vein here?
Yes.
Yeah, because the bleed was somewhere here, and we have disconnected the vein from that side already. See, you can see the clips on. Can you see the clips?
Is that for the vein?
See, there is one clip on the aneurysm, and there's one clip on this large vein which was dilating up. So this was an emergency surgery. So they had put a clip on this.
Where was that vein coming from?
It was a funny thing, I mean, I was called in during the surgery, so we thought that this vein was coming all the way from the posterior fossa. It was strange actually.
Oh, I see.
But we couldn't. It was a very small A1, and there was this large vessel. We couldn't even identify if it's a vein or an artery because there was no angiogram at that time, and there was just a bleed. I mean, this patient came in with just a bleed, So and it had to be evacuated. The hematoma was evacuated. And then after that, we went in and did this angio. So I'm concerned. You see that pepper pot pattern here. You see that?
Yeah.
I would rather do. I mean, what I was planning to do. I understand that if you want me to just disconnect this, should be quite all right actually. Just disconnect the.
So, but this is in the orbit actually. This is the ophthalmic artery, then comes out through the ethmoidal foramens here, and I think so from the anterior ethmoidal foramen that it forms a fistula there, and then a cortical vein is being connected to that fistula, and that's where the venous varix is. So if you have to disconnect that fistula communication, it's better to go intradurally there and then disconnect it. There also seems the carotid circulation maybe it's because of the hematoma and the swelling and spasm. There is some MCA circulation here, but you don't see the branches clearly. Maybe there is spasm as well related to the hematoma.
Yeah, I mean, I can show you the. You see that?
Yeah. So where is that training into the straight sinus? That.
Yeah. It's going into the deep sinuses. You see now that's a small.
Connecting to the.
Yeah, that's an MCL. It's a small A1. The A1 was very small.
Yeah.
And you see.
Yeah. So that's deep sinus going into the deep vein. So I think that.
So.
Is that the vein you saw from the first lateral view picture? That vein is coming from that, isn't it? So I think that vein is in the medial hemisphere, medial aspect of the frontal lobe, and then through the medial aspect of the temporal lobe, going towards connecting into the medial veins, then going into the deep venous system.
It's coming lateral to the carotid, Ramesh. It's coming lateral to the carotid. The opticocarotid.
I'm talking about the medial temporal lobe vein. You know the medial veins of the cerebral hemisphere. So this vein is being connected to that medial vein, then going into the basal veins and then into the straight sinus.
So I would expose the feeders, then, but I will disconnect somewhere here.
Yeah, I think if you do a standard craniotomy, then see the anticraniofossa floor, and you can disconnect the origin of the vein there, and that should be sufficient to disconnect this venous communication.
Yeah. I just wanted to show it because you were showing.
That's great, actually. Quite good to have similar cases. So let me just go back to that second case I wanted to show. Desktop. So this is. It's not connected. Is it connected or not connected? Are you able to see now?
Yeah, we are able to see.
Okay, so the second one is not a new case. I thought I'll just show another skull-based case which I had some difficulty with. This is a 38-year-old investment banker in London, and was admitted to his local hospital with a progressive headache and ongoing blurring of his vision. And in spite of being a highly intelligent person, he never took notice of his symptoms. Only when the visual deterioration became so prominent, he went to hospital with a progressive headache. And this was a scan that was done in the local hospital. So this essentially is a solid and cystic lesion, and mainly the suprasellar location, occupying the suprasellar space. So this was a sort of a typical appearance of a craniopharyngioma given his age, and he had a bitemporal hemianopia mainly, but a small visual loss on one side. And see, these sort of tumors, I would prefer these days an endoscopic, extended endoscopic approach. That approach to be extremely useful to remove these lesions. Previously, I've been doing a standard frontotemporal approach for this. Then you have a lot of hidden corners with that approach, and also the neurovascular structures will be directly in your way. Whichever side you choose, the optic nerve and the carotid artery will be working between these structures, either interoptic or carotid optic window or retrocarotid window. You'll be working through the space. But once I started doing this extended endonasal approaches, these lesions appear to be treated really well with this endoscopic approaches. So I just show just a very brief anatomy to explain why that is, why this approach is convenient for this suprasellar craniopharyngiomas. So this is the kind of anatomy you have to be aware of doing an endonasal approach, and you are looking from inside the sphenoid sinus. Okay, this is a transsphenoid operation, and a sphenoid cavity is your room. This is where you have to work out, and depending on the extent of the lesion, which part of the bone you have to remove. So just go through the structures again. This is the pituitary gland. So the bone is all removed, and you can still see the dura of the cellular flow. And this depression you see here is the tuberculum, the ridge, the tuberculum cellae here, and these are the optic nerve impressions. And you see the opticocarotid recess, the lateral opticocarotid recess, essentially is the antideclinal process, and then you also have a medial opticocarotid recess. And the one thing which we have to remember is that the cavernous carotid is just lateral to the exposure, and it's important to know, even without navigation systems, to know where these structures are. If you depend too much on navigation system, the navigation system can have a millimeter or two of inaccuracy when drilling the structures here. We've had a case where the drilling was entirely over the carotid and led to carotid injury. So you have to go by an anatomical landmark, and this is the clival recess. So behind the pituitary gland, this is the clival recess. This is the favorite part of this anatomy, because this is where I rest my instruments, the sucker, whenever you're not using it, because it's two-handed approach. You put your instrument, I use the suction here, keep my instrument when I'm trying to clear up space here, and so this is the anatomy you have in this location. You have the paraclival carotids here, and that anatomy is relevant when you're exposing the clivus region for clival meningiomas or chondrosarcomas or chondroid chondroid tumors. This is where you work. Again, the carotid is exposed, and you see the entire carotid. And I heard I'm talking about the carotid anatomy on lateral views in many meetings. So this is the anatomy you see from the inferior aspect, and this is the planum, which is in front of the tuberculum sella. You have the planum. So in many operations of extended endonasal approaches, this is the part of the bone you remove. It's almost like a V-shaped area. So you have to understand this anatomy is slightly distorted, not the normal anatomy you see with the cadaver exposure. So the extended bone you remove depending on the lesion you encounter. If you have a meningioma, you may have to go lateral to the extent of the meningioma to sect off the meningioma completely. And to give you an anatomy, it's not the same patient, but say this patient has had a pituitary fibrous granuloma. So this anatomy is quite. This is the clival recess I was talking about, and this is tuberculum sella. There's a septation within the sphenoid sinus. As often these septations go to one side, and they most often reach towards the carotid. So that's the middle. So this is the middle. The midline you always have to keep an idea about. The oma, the midline septum, you just keep that in mind all the time. So you keep that midline in your mind all the time, then you decide how laterally you can go. Rather than trying to depend on the navigation system. This white area you see here are the impressions of the optic nerve and then the opticocarotid recess. So I'm just drilling. So okay, so this is the floor of the pituitary fossa is being removed. Then you can extend this incision anteriorly as well. The optic nerve is here. The other optic nerve is here. This part of the bone will be very thick. The floor is very thin, but this is very thick. So you may have to drill and then remove it. And drilling this part will involve tackling the anterior intercavernous sinus. Often it can be prominent and can lead to some bleeding, which can be controlled with spongestan or similar material. We use something called Liostip here. The particular case I was talking about is a young man with craniopharyngioma. This is his first operation. And you can see the tuberculum sella and the planum is removed, the dura is opened. So this is the tumor, the craniopharyngioma. There is an arachnoid covering to it. A lot of stuff you can see inside the tumor there. And this is the pituitary gland here. So we are in front of the pituitary gland. Optic nerves are here. This is the optic nerve on this side. The other optic nerve is on this side. The chiasm is already there. And this is in this approach, you cannot use a lot of instruments. So you have to be comfortable with one or two instruments you are familiar with. Then try and do it safely and carefully. The one advantage of this approach is that you can even see tiny blood vessels before you cut things, and you should not do any blind division or blind pulling, so that once you get the blade, then it may be difficult to control. Let me just fast forward a little bit. So this is the So that part of the, I mean, after a while, your field will get a bit more blurry because there will be staining of the blood. The endoscope we have has got an sort of integrated cleaning system at the tip of the endoscope, and you can wash the tip rather than taking it out. It's called endoscrub. So we're just going to go with the and this operation, the endoscope is held by my ENT colleague. So they will be they are the drivers. They will show you the way, and then you do the operation. So they will be holding the endoscope. It's possible to have a endoscope holder or something, but this is much more active. You can go in and out depending on, if you work as a team, your colleague will know what you need, and they will provide you with that kind of exposure. But if for somebody who's not familiar with your approach, you can have a lot of problems because they may not hold the endoscope very steady. They will be shaking a bit, and eventually you get seasick, and it happens all the time. So they move the endoscope quite a lot, and then you will that will distract you and give you some dizziness. And as you can see, this is a 2D picture. You'll be watching this on the screen rather than watching through the scope. So you're working with your two-dimensional depth. So that means that when you put instruments in, when you catch things, your depth perception is by your movements of your instruments. The way you move it, you know how deep that is. This is the tumor that is being reflected, and I found that the tumor was attached to the pituitary stalk at that time. So I didn't want to give him a diabetes insipidus. So I left a layer of tumor on the pituitary stalk at that time, but removed the rest of the tumor, including part of the tumor that was coming from the undersurface of the chiasm. So the question at that time was whether it's worth it trying to remove the whole tumor by removing the stalk as well. Then you will have a lifelong diabetes insipidus. And so what I did at that time was to avoid damaging the pituitary stalk. I left a small bit of a tumor onto the pituitary stalk, and then resected the rest of the tumor. So let's see if I can get some good quality. So you can see the two instruments. I used both the nostrils to access the space. One hand, with the right hand, through the right nostrils, I use the instruments like a hook or dissector or something. Then with the left, to the left nostril, I use the suction. And then you can see the stalk also with the tumor attached to it. So this is the part which I was concerned about. So I decided to leave some tumor on it. I didn't remove the whole of the stalk at that time. Just to the next slide. So I suspect this is the same. Okay, this is again the same case, same operation. So you can see this, the anatomy once the tumor is removed. These two structures are the mammillary bodies. There's the floor of the third ventricle here. Tumor is attached here, and you can see the PCA branches here. We'll see a better view later on when the blood is cleared up. So this is again, you can see the part of the tumor that is coming along with the stalk here. I'm just going inside and having a look. That's the area where the third ventricular fold was affected by the tumor. You can see the third nerve just about in that lower part, and field free to stop me at any point if you have any clarify something, Rakesh and Simon. So I'm happy to stop here to answer any questions. Let me just move on to the. So just looking at the stalk with some tumor, you can see the stalk is a bit bulky. The tumor is inside here. I could have taken it that time, but then decided not to. So he did have a very good outcome following the operation. His visual deficit completely resolved. He became asymptomatic. He didn't have any complications related to the leak. And what we do, this sort of approach, is that we repair the defect with a nasoceptive flap, which was taken from the nasal mucosa and then was sewn back onto the defect to cover it, and then glues to cover it. And he came back, I think, almost 6 months later with a further large cyst in the same location. So he had a recurrence. And initially, I waited for a few months and had another scan. That cyst was getting bigger. So I decided to get him back to theater for a redo operation. So this is what you find in redo extended endoscopic procedures. So the flap, as you can see, the flap is taken up very well. This is the appearance from inside the sphenoid sinus. This is the flap you use. The whole thing was a flap, and it's taken up very nicely. It's well healed, and this is one situation where the navigation would be, it'll be, because the normal landmarks are not there. You have to take, this is a choana, and this is the previous resected edges here. This is a posterior phalangeal wall here. That's the sphenoid sinus. This flap is here. So this is the appearance, you see it, and then once you've taken it out, so the appearance is much clearer here. So once we go in, you can see the basilar artery here, the superior cerebral artery going here, and the basilar quadrification, mainly the left superior cerebral artery, the left PCA, the right PCA, the P1 here, and you have the medial posterior choroidal arteries here, and some of the thalamoperforators, the PCOM coming here. You can see that this P1 is not big, but the PCOM is big. On the left side, you have a bigger P1, and you can see the third now just about there. The mammillary bodies are here, and 2 mammillary bodies. The floor is already deficient by the previous operation. You can see the third wonderful tooth there. Let me just run this video. And so you can see, so this is the video here, and let me just move it a little bit. So this is the cyst. I've taken some of the cyst out, but this is the part of the cyst that is attached to the pituitary stalk on the left side. Again, this time the intention was to dissect the to ligate or divide the pituitary stalk, and he was consented appropriately for a division of the pituitary stalk this time. So we knew that he was going to get a permanent DI. It wasn't too bad, as we expected, because they do eventually will get adjusted to their lifestyle with maybe a nighttime dose of a DDAVP, and so the tumor is being completely resected this time. So this is that stalk is being now removed. This is the previous flap here. So just dividing the stalk and the rest of the tumor. So it was a total excision at that time. So the point about this particular case is that sometimes you may wonder whether it's justifiable dividing the stalk or not. But in this case, it was. I learned it after the second operation. And he had, it's been almost, I think, 3 years now. He had the second operation, and see if I can see something. So this is the So you can see the third nerve there, the posterior clinoid here, the basilar artery here. So that makes you wonder whether if you have any difficult lesions of the basilar artery, like an aneurysm in the or the SCA P1 junction, this may be a good approach if there is no endovascular. That third nerve here between the superior cerebellar and the PCA here. So some of the cases you may want to approach it. Some of the vascular lesion can be approached through it. The P1 on the left side, the PCOM here, the mammillary glands. So this anatomy is extremely well defined in this case. So I'll just move on to that is, I suspect is after the second operation. The thickened flap you see here is the flap which enhances with the dye. So it's not a residual tumor, and it is fine. So this is the second case. So if any comment to make, I'll be very keen to hear it. But if not, if I have time, there's one case which I would like to get some opinion about it, mainly from IPE and others.
Thank you. Thank you, Dr. Nair. Thank you for your presentation. Before we go any further and perhaps ask some questions, I'd like to first introduce Roberto Herrera, doctor, a neurosurgeon from Argentina, and he has come to join our session.
Hi, Roberto. I think you're
Hi there, Roberto. Hi, Roberto.
And also we're joined by Slaven. Slaven is a medical student.
Hi, Slaven.
From Croatia.
Hello, very nice to meet you, and I'm really honored to be in this circle. Thank you.
Thank you, Slaven. So if we can continue, and maybe we can ask a few questions before we continue on, perhaps to have a look at that third case.
Yeah.
Okay. If there are any questions, please go ahead and ask.
Excellent job, Ramesh. Very good job. That makes me really tempted to start, endoscopic approaches. As you said, the basilar looks very tempting from there.
Yeah. In fact, you remember I operate in this location for many other lesions. So once I had an ACOM, and I had done an operation for that lady before. So when she had an unruptured ACOM at that level, rather than opening in my previous craniotomy, I thought about going through the nose to clip the ACOM for that lady, which went really well. So you could tackle the vascular lesions for the right indications. I wouldn't just do it for the sake of it, because hot aneurysm is more tricky, because once you get a bleed or interrupted rupture with this endoscopic approaches, it's a very difficult position to salvage from. Whatever you do, once you get your blood, once you get your vision obscured, the main thing about this approach is your vision. And even with a suboptimal endoscope, it will be very difficult to do this operation. So one thing we should insist is the quality of your vision. So that's why lesions, especially acute lesions with the potential to bleed, they are high risk for endoscopic approach. But it is.
Hello.
Yes, can you hear me?
Yeah, I get you. I understand you. But it's very tempting. It looks very tempting. Seriously.
Yes.
Thank you. And are there any other questions from the panelists?
No, just a comment. Excellent videos. Really, really clear videos. Very easy to watch. I'm a neurosurgeon.
I had one question, just a basic question. I'm wondering about on the clinical. You mentioned that.
What was it, Simon?
Oh, please go ahead.
No, you said something. I missed that bit. What did you say?
I was just asking if there were any more questions from the panelists.
Sure. Yeah.
I was just.
Rakesh, do you have any questions?
Well, I'm still a beginner in this. It's a very excellent presentation, and I should go through the anatomy. Yeah.
Yeah, I think the anatomy is great. It's slightly different anatomy from an endoscopic view.
Yes, sir.
Because the anatomy is distorted with an endoscope, but the anatomy is excellent through these approaches. and
Yes,
those you never could see with the transcranial approach, the endoscopic approach.
The anatomy was clear. The pictures were clear, sir. Thank you.
Thanks.
I have one question regarding the clinical presentation. Since you mentioned that the patient presented with a headache, would you also see inferior? I was reading about the case inferior quadrantopia and hemianopsia. Would both of those be seen in presentation?
Well, with the craniopharyngiomas and the pituitary tumors, they start with chondrodynopia to begin with. The smaller lesions pushing the chiasm up, you will get chondrodynopia at the beginning. And depending on where the location is, and that is slightly different for pituitary tumors and craniopharyngiomas, and you would remember the difference. The pituitary tumors, they tend to take off the inferior fibers, and they start with the superior chondrotic defect. But theoretically, the craniopharyngiomas, they tend to take the lower quadrant first and then go up. But eventually, with the further lesions, further enlargement of the lesion, you get bitemporal hemianopia. That is the kind of classical hemianopia you get with supracellular tumors. It's a bitemporal effect. So you take out the nasal fibers which are crossing, so then you get the bitemporal field deficit. But it can start with the chondrodynopia, as you said. Yeah.
I see. Thank you very much.
Yes, I just want to add this. This is a classical question in the MCQs for the neurosurgery resident, and it says that in pituitary tumors, it's on the right eye, it is in the clockwise direction. And in the craniopharyngioma, it's anti-clockwise direction. I just remember that. So.
If there's no more further questions, I have just one case. If I do, I have another 5 minutes, John.
Yes, we do.
Okay, so let me just go back to my desktop.
That is, if it's okay with Roberto.
Is it? Is it wrong? Yeah, so I'm just going to show you some pictures of this case I have at this moment. I haven't anonymized it yet, but I thought I'll just show it for the sake of discussion here. So this is a retired biochemist with me at the moment. He's 64, and he don't have some visual problem for some time, which they attributed to his cataract, and he eventually went on to have his cataract done. He had this cataract done in one eye, and then his visual field deficit persisted. Then had an MRI scan done. As you can see in this MRI, this is the T2 weighted MRI scan showing an extensive lesion of the skull base here in the pixella, and the carotids are here. So just go through the other. Maybe I can show this one here. Is this big? Okay.
Okay. Yeah, we can see it well.
Yeah. So this is the sort of a basal slice of the MRI scan showing extensive lesion around the cellular area, going lateral to the carotid here, encasing the carotid on this side. I'm just trying to find a way to maybe I can select all this and then. Select all. I don't know whether I can do it. Okay. Okay, I guess I have to.
Yeah, sometimes we have a hard time maximizing the screen.
Yeah, so I just go through some of the.
Yeah, that's a small screen.
Yeah, I'm just gonna open up one by one and then.
Okay.
So this is the. This is another view. Again, you can see the carotids are displaced on either side with this large cellular tumor. And then So again, further slices, you can see the displacement of the carotid. The tumor is already extending laterally into the temporal lobe there. You can see the tumor is becoming supracellular. Part of the tumor is occupying the sylvian fissure there. Essentially, this is a large pituitary tumor with a lot of invasion into the cavernous sinus and the temporal lobe on the left side. Okay, let me just take another one or two pictures before I just start. You can see that it's occupying the whole of the skull base here, eroded the upper clivus, and going up into the supracellular system. This tumor has pushed up his chiasm and thinned out his chiasm. And then extended the carotid is wrapped around that side, which is on the left side. Okay, let me. This is the side view of the scan here. I'll just show you a coronal view as well. So you can see the extent of the tumor. The carotids are within the tumor here, and the supraclinoid ICA. This is the intracavernous ICA, which is being lifted up by the extension of this tumor under the carotid there. That's the two the carotids, the supraclinoid ICA on the right side. Tumor has extended into the sylvian fissure there. There's a big cyst in the left sylvian fissure. I'll show you one more picture, and then we'll. So essentially, this is a large pituitary tumor with a lot of extension into the cavernous sinus, displacing the cavernous sinus and displacing the carotid, thinning out the chiasm there and extending onto the left temporal fossa. In this, he definitely needed an operation given the visual deterioration, and endocrinologically, it wasn't too bad. There wasn't any major endocrine dysfunction with him, even though he did appear to have slightly reduced cortisol axis. So I just want to pause at this stage to discuss the various options I have. Normally, for a large tumor like this, my approach would be, even if it's a giant pituitary adenoma, my approach would be a endonasal approach. If needed, an extended endonasal approach to try and remove the tumors. I'd like to get some comment on whether one should do a craniotomy in the first instance, or to consider an endonasal approach to reduce the supracellular bulk first, and then come at a later stage to the site to take out that sylvian fissure component. Given that the main concern at this stage was the chiasmal compromise and its visual deterioration. Any comment at this stage? For Roberto or Simon or Rakesh or Clavan?
Yeah, Ramesh, first thing first.
Yeah.
We've had a few of these tumors, and looking at this kind of a tumor where the patient is relatively preserved.
Yeah.
Can you hear me? Can you hear me, all of you?
Yeah, I can hear you very well. Yeah.
Yes.
Yeah, we can hear you.
Yeah. So this patient is relatively well preserved. So and with this kind of a large tumor. So the best thing about this tumor is its consistency. So it's going to be a soft tumor. I would imagine that 70% of the time, I would imagine that this is a soft tumor. Yeah. That itself makes the approach. I mean, I'm not sure of this. I'm not sure of this. But if it was a meningioma, which would be encasing everything like this, I would expect some cranial nerve palsy. I would expect some pituitary problem. So this is going to be a soft tumor. Yeah. This is what I would expect. But on the other hand, I would go bicoronal, and I would extend. I would go bicoronal, and then extend it on the left side, like a frontotemporal. I hope you understanding what I mean, right?
You mean bicoronal skin incision or a bicoronal flap?
A bicoronal flap which will extend on the left side like a frontotemporal.
Oh, I see. So bifrontal craniotomy and then a frontotemporal on the left side, sort of expanding that bifrontal to the left side.
Yes, this is what I always do. I mean, and then I will go Dolenz on the left side. I will do a clinoidectomy. I will do transcavernous dissection, and I'm going to find the tumor there. Extradurally itself, I'm going to find the tumor most probably. And I mean, if the patient does not have any cranial nerve palsy, extending the corridor between 4 and V1 is generally, if you try and extend the corridor between 4 and V1 for a soft tumor. For a meningioma, I would never advise this, but if you extend the corridor between 4 and V1, dissect the 4 right up to the superior orbital fissure, dissect it as back as possible, dissect the V1, and you can even put the V1 down. You can retract the V1 slightly down, and generally there will be tumor coming out through this area. Yeah. So if you can dissect that and then get on to and start decompressing the tumor as much as possible, then when you get intradurally, if you drill a little bit of your plenum region here, yeah. And if the brain is going to be lax, you can go to the opposite side also. And if it is a soft tumor, this would not be, it will not be too much trouble removing. But I would be really concerned with the part going right into the clivus, because there I am just going to put my suction and suck blindly, because unless, even if I open the diaphragma sella from the suprasellar region, the vision is not going to be so great with the microscope, because this tumor is extensive. There's going to be, of course, some bleeding. You're going to be worried about the cavernous branches of the IC, so you cannot put your large suction in and just do a terminator job. You cannot do a terminator job. So you have to be very, very sure. You have to be very clear, and you have to be from the bicoronal and from the FOZ flap transcavernous dissection. I believe that you can take out more than 90% of this tumor.
Okay.
I would like to hear what Roberto would have to say.
Yeah. Okay. Well, I as you say, I operated this guy. I think week before last. As I said, my options were to debulk the chiasm through a transphenoidal route, because I thought this was a pituitary tumor, quite extensive pituitary tumor. My intention was to debulk the chiasm, as that was the primary concern for him. And he can do a lot of debulking through endoscopic approach to take out this bit of the tumor. But then the part which is going laterally, you would need a second stage operation to remove the cranial bit. So that was not that was not causing him any symptoms at all. It was mainly the chiasmal compromise that was the issue with this man. So then I did have a discussion with another skull-based colleague of mine who had a similar case in the past, and he did it endonasally, microsurgical transvenous operation for this similar case, and eventually, with possibly related to the shift of the structures, the vascular structures, that patient did have a stroke. So I was a bit concerned by that anecdotal case, even though it may not happen. I was concerned that if I debulk it, if I stretch the carotids, and if I pull off, so you can see some of the scans showing the MCA branches going through it. Let me see if I have some So there are some branches of the NCA, especially perforators, that are already within this tumor. So I was concerned about possible risk of stroke with the transphenol decompression first in an attempt to decompose the chiasm. So at the end, I decided to do a standard hedional craniotomy on the left side to remove the Sylvian fissure part of the tumor, and then debulk as much as possible from the left side, because there was a cyst on the left side, and I could take out that bit without any major concern. So then, as much as I could possibly try and decompose the optic chiasm through the left frontotemporal approach. Unfortunately, the video of that case it was in another it was a different microscope, so I forgot to copy that video, but I show you the post-op MR. This is the post-op MR. You can see the lesion within the Sylvian fissure is all taken out, but I couldn't do much with the large suprasellar bit. I could create some space for the chiasm. So this is the bit that is all taken out. I created a cavity within the cellar. Again, you can see that bit of the tumor is taken out. The rest of the tumor is still there. So he's going to require another operation at some stage, maybe in the next few months' time. But the part of the cranial bit of the tumor is taken out. And the reason I did the cranial approach first was to try and avoid any shift of the vascular structures during a transsphenoid operation first. But this part of the tumor needs a transsphenoid operation, and that can be eminently resected through an endoscopic approach. But I doubt whether it's going to be a total excision given the extensive nature of it. But it's not an urgent issue now, because the cavity you see here will eventually, in our experience, they will collapse down until the chiasm will be free of any pressure once you debulk the top part of the tumor. But this guy is going to require another operation. He's still with me. He's got some low sodium, but he's otherwise well. The thing I found with this case is that when I was debulking the suprasellar bit, the third nerve was completely wrapped around the tumor on the left side, and where the third nerve enters onto the cavernous sinus, it was completely stretched out. I knew even if I tried to mobilize it or dissect it, it will lead to third nerve damage. So I debulked that bit around the third nerve, but even then I had to leave some tumor around the third nerve. But even then, he did develop a partial third nerve palsy. He's got a partial ptosis, but he's able to move his eyes on both sides, so it's not a complete third nerve. So I'm hoping that this will recover in course of time. So,
what was the consistency of this tumor?
So it's a good point. The consistency, as you said, it was. Are you able to see me now?
Yes.
So the consistency, the Sylvian fissure bulk of the tumor was soft. So initially I went into Sylvian fissure to debulk it, was very soft. Then you lose some orientation. So I had to go back to the basal cisterns and follow the carotid, and part of the tumor that was going into the Sylvian fissure. So that was all debulked completely. It was all soft, but so once I did the temporal bit, I went inside the tumor through the opticocarotid window and the interoptic space, and some of it was soft, but some of it is firm as well. So if it was all completely soft, probably I would have taken more tumor out through that approach, but it wasn't that, and I tried to curate it. It was like a fleshy tumor, but it was a pituitary tumor. The histology was a pituitary tumor.
Okay, thank you very much, Dr. Nair, for your presentation. We had a wonderful experience, learned so much, and We'll now be moving on and to our next presentation, and we'd like to thank all the panel members for coming today. And Dr. Bennett, do you have any comment?
Thank you.